Next, we move on to our last session of Hall B. The topic is the role of CGMS in gestational diabetes mellitus. I would like to call the chairperson first, Dr. Vibha Gupta, Dr. Nirmala Pipara, Dr. Abha Saraf, and Dr. Bindu Rohatgi, ma'am. And the speaker of this session will be Dr. Ojha, sir. So please come on, dais, sir.
As we know, diabetes has become a burning high incidence in our pregnant ladies. Diabetes incidence around 10% in pregnancy, and GDM add up to further 10%. So we want the strict monitoring because of the health of the baby and as well as the mother. So now I invite Dr. Ojha to present the continuous monitoring role of continuous monitoring in diabetes during pregnancy.
Thank you, ma'am. At the outset, I would like to thank the organizers to give me the opportunity to speak on the topic of role of CGMS in gestational diabetes. As we know that the therapy of diabetes and the glycemic management patterns have evolved quite a lot in last few years. CGMS is the most advanced form of the glycemic management that we have nowadays. At the outset, I would like to say that there is no clear-cut guideline with regard to role of CGMS in the diabetes, gestational diabetes mellitus, gestational diabetes. But this form of measurement of blood glucose is evolving. It is nowadays the gold standard of glucose management in all the randomized controlled trials. As we know that the evolution of glycemic management has been tremendous in last decades, and so is the glycemic markers. HbA1c had been the gold standard of the glycemic control management over maybe last 2 decades, and it is a good indicator of diabetes control. But only the fasting blood glucose and PP blood glucose and HbA1c is no longer remain the gold standard of the diabetes control markers. Beside these 3 markers, we also have to measure the glucose variability, and simultaneously we have to avoid hypoglycemia to improve the clinical outcomes. So new glycemic targets had been recognized, and one of those is time in range. That is, time in range is the proportion or the percentage of the time that a patient spends in the ideal blood glucose range, which had been defined as 70 to 180 milligram per cent. So it is said that if a person spends 70% or more of his time, overall time, between 70 to 180 milligram per cent, he is bound to have a good HbA1c at the end of 3 months. Anything above time in range is called time above range, which is if it is more than 180 up to 250, and beyond 250 is very high. So up to 180 to 250 is high, and one should not have more than one should have less than 25% of time above range, and once if it is less than 70, then it is called time below range, and it should be less than 5% of the overall time spent. And the coefficient of the variability should be 36%, less than 36%. So these are the new glycemic target which had been recognized, and this is for all types of diabetics, not only the pregnant diabetics. So this is what I have explained you, that the time in range should be 70% or more, the time above range should be less than 25% and very high should be less than 5%. Similarly, the time below range should be less than 5% and very low, which is less than 45%, 54 milligram percent should be less than 1%. So, how to measure this time in range and the glycemic pattern over the days, over the hours or over the weeks? We have got a modality called continuous glucose measurement, and this is how the reports is reported. It comes, if you look at on the right hand side, there are two green lines, and that is between 70 to 180. It is ideal that the one person spends more than 70% of the time in between these two lines. Anything below is the hypoglycemia and anything above is the hyperglycemia. There had been different TIR targets for different diabetic populations, and if you come in type 1 and type 2 diabetes, which are not very high risk, I have already explained to you, but if the patient of type 1 or type 2 diabetes is of high risk, then one can have a time in range just above 50%. The time above range should be less than 50%, but the hypoglycemia should be avoided at all costs, and the time below range should be ideally be less than 1% in high risk patients. But in pregnancy, the targets are different. Even the time in range is different. The time in range for pregnancy is not between 70 to 180 milligram percent, it should be 63 to 140 milligram percent. So and in a type 1 diabetes, the pregnant female should spend more than 70% in between 63 to 140 milligram percent. She should be spending less than 25% of total time above 140 milligram percent, and she should be spending less than 5% below 63 milligram percent. So avoidance of hyperglycemia and hypoglycemia both are very important in type 1 diabetes pregnancy. But for gestational diabetes, the time in range are all the same. The time above range are same, time below the range is same. But they should be spending around 90% of the time in range, because these are the milder form of diabetes in pregnancy. So they should be having as much time and possible in time in range. Why is the fuss? We all know that the prevalence of diabetes in pregnancy has been increasing worldwide, and it is in parallel with the worldwide epidemics of obesity. Not only is the prevalence of type 1 diabetes and type 2 diabetes increasing in women of reproductive age, but there is also a dramatic increase in the reported cases of gestational diabetes mellitus. Diabetes confers significantly greater maternal and fetal risk, which is largely related to the degree of hyperglycemia, but it is also related to chronic complications and comorbidity in diabetes. In general, specific risk of diabetes in pregnancy includes spontaneous abortion, fetal anomalies, preeclampsia, fetal demise, macrosomia, neonatal hypoglycemia, neonatal hyperbilirubinemia, and neonatal respiratory distress syndrome. In addition, if there is an exposure to hyperglycemia in utero, it increases the risk of obesity, hypertension, and type 2 diabetes mellitus in offspring in later life. What is the role of glycemic variability? What harms the glycemic variability if it is too much in a pregnancy? So this is an article published in by Vishwani, Khurana, Aruna Nigam and Arpita De, where they found that if there is mean average glycemic excursion is more than 55 milligram percent, it was associated with adverse fetal outcome such as large for gestational age infants, neonatal hypoglycemia and stillbirth. In the type 2 diabetes group, poor outcomes were linked to a high time above average range. The large for gestational age subgroup exhibited an elevated time above the range compared to those with normal outcome. So the patient who spend more time above the range, they have a poorer outcome. So they concluded that pregnant women with type 2 diabetes exhibited higher glycemic variability compared to healthy pregnant women. and a mean average glycemic excursion of more than 55 milligram per deciliter was associated with adverse fetal outcome, and elevated time above range significantly influences these outcomes, and this was published as recently as January 2025. Does the better blood glucose control affects pregnancy in a favorable way? And this was the article published in International Journal of Clinical and Experimental Medicine in 2019. According to this, they have studied two groups of women who were divided into group 1, where 39 pregnants without ideal blood glucose control were kept, and in another group 2, 61 pregnant women with ideal blood glucose control were assigned. Complications, pregnancy outcomes, neonatal complications were compared between the two groups, and they found that the incidence of complication during pregnancy in group 1, which was poorly controlled, was higher than in group 2. In terms of neonatal complications, the incidence of infection, hypoglycemia and respiratory distress syndrome in group 1 was markedly higher than those in group 2. So, a poorer glucose control leads to adverse outcome, and a better glucose leads to improved outcome. Let us see what is the glycemic variability in its relation with the large for gestational age, and this was the studies published in the JAPI in 2023. They have concluded that high glycemic variability and time in range are the important parameters that can be well correlated with large for gestational age babies in gestational diabetes pregnancy who are on pharmacotherapy. This is not applicable for the patient who are controlled on diet only. And flash glucose measurement is a good monitoring device to measure this parameter and can be used as an adjunct to modify measures to control the glucose values within range in these pregnancies. The importance of glycemic variability of pregnant women with GDM cannot be ignored. The glycemic variability of pregnant women with GDM is significantly higher than that of a pregnant woman with normal non-diabetic pregnancy. Many studies have shown certain correlation between glycemic variability and adverse outcome of pregnant women with gestational diabetes. Therefore, clinicians need to pay more attention how to control the glycemic variability. And control of glycemic variability has a definite impact on improving outcome of the GDM pregnancies. The application of CGM systems can control GB better than SMBG, obtain the dynamic blood glucose curves of patients with GDM, and monitor more blood glucose control abnormalities. Not only the glycemic variability, even the trajectory of glycemic variability affects the pregnancy outcome. If the trajectory is very fast, there is significant glycemic variability, but it is changing very fast, then it also affects adversely. Not only the glycemic variability, even the trajectory affects the pregnancy outcome adversely. We have been assessing the glycemic control traditionally with measuring fasting blood glucose, PP blood glucose, and the HbA1c. Glucose goals are fasting blood glucose is less than 95 milligram percent, less than 140 milligram percent after 1 hour meal, and less than 120 milligram percent after 2 hours of meal in pregnancy. Ideally, the HbA1c goal in pregnancy should be less than 6% if it can be achieved without significant hypoglycemia. But the goal may be relaxed if to less than 7 if necessary to prevent hypoglycemia. In the second and third trimester of pregnancy, HbA1c less than 6 has the lowest risk of large for gestational age infants, preterm delivery, and preeclampsia. Taking all this into the account, a goal of less than 6% is optimal during pregnancy if it can be achieved without significant hypoglycemia, which itself is a adverse sequelae, may increase the risk of low birth weight. So HbA1c has served us well in past because it correlates well with the average blood glucose level. It predicts future complications because it is a good risk marker used in all diabetic guidelines. It is easy to measurable and understand, and it is easily available nowadays, and it gives a medium to long-term target setting. However, it only provides an average picture of blood glucose control. It is not always reliable. especially in cases of hemoglobinopathies, anemia, uremia, ethnicity, fails to provide data on hypoglycemia and glucose variability. Due to physiological increase in red blood cell turnover, HbA1c levels fall during normal pregnancy, it underestimates hyperglycemia. Additionally, HbA1c represents an integrated measure of glucose. It may not be fully capturing the postprandial hyperglycemia, which drives macrosomia. Thus, although HbA1c may be useful, it should be used as a secondary measure of glycemic outcomes in pregnancy after blood glucose monitoring. So, SMBG along with HbA1c is better rather than doing only HbA1c. Given the alteration in the red blood cell kinetics during pregnancy and physiological changes in glycemic parameters, HbA1c level, if being used, should be monitored more frequently than usual, maybe monthly. And the alternative of HbA1c are SMBGs and CGMS. SMBG has got disadvantage because it lacks the continuous glucose data providing, it potentially leading to delayed detection of dangerous high and low blood glucose level because we only measure when something has already happened, and it also doesn't give any clue of the glycemic variability. But it has got certain advantage because it is available at a lower cost and it is widely available. If you use CGMS as a tool for glycemic control measurement, it has got definite advantage. It provides glucose reading every few minutes, offering in a comprehensive picture of glucose fluctuation throughout the day and night. This is in contrast to SMBG, which provides only a few snapshots per day. It gives real-time alerts, it improves glycemic control, and there is reduced risk of adverse outcome. Studies like concept trial have shown that CGMS used in pregnancy is associated with improved neonatal outcomes, including reduced rate of large for gestational age babies, neonatal hypoglycemia, and ICU admission. Also, there is enhanced patient satisfaction which had been found when CGMS had been conducted over the pregnant women and the patient women have been interviewed. There is always a better understanding of glucose variability when we use the CGMS. And there are few studies which had been done to study the effects of CGMS and SMBG on maternal and neonatal outcomes in gestational diabetes. This was a randomized controlled trial which was published in Nature. They have concluded that CGMS provides a detailed depiction of the glycemic variability. However, whether the generated reading improves pregnancy outcome is not clear. They found that their results suggested that the use of supplementary CGMS by GDM mothers was associated with reduced weight gain. In addition, lower maternal weight gain was observed when the CGMS were used during the second trimester rather than the third trimester. This result implies that the early implementation of CGMS can reduce weight gain among women with GDM. There had been no significant difference in other prenatal and obstetrical outcome were observed between the CGMS and SMBG group. The CGMS group had a lower proportion of large for gestational age neonates and lower HbA1c level than the SMBG group. However, these differences were not statistically significant. Many studies have collected evidence to support the benefit of real-time CGMS in type 1 diabetes during pregnancy. The largest randomized controlled trial, RCT, continues in type 1 diabetes, which is a concept trial to compare the effectiveness of real-time CGMS with that of SMBG, showed 0.2% lower HbA1c at 34 weeks of gestation, those using real-time CGMS. In addition, the percentage time in range was 7% higher and time in range was time above the range was 5% less in patient using CGMS group than the control group without an increase in hypoglycemia. This glycemic improvement led to improved neonatal outcome, including LGA, neonatal hypoglycemia, and admission to the neonatal intensive care unit in first 24 hours. However, even with the real-time CGMS, only 66% reached the target of HbA1c less than 6.5%. The mean percentage time in range was 68% and did not reach the target of 70%. and 1 in the 2 neonates experience large for gestational age. The risk of diabetes-related complication during pregnancy is higher for those with type 1 diabetes than type 2 diabetes. However, in case of pre-gestational type 2 diabetes, the risk of complication that lead to stillbirth and neonatal death is even greater than in type 1 diabetes. Improving glycemic outcomes from people with type 2 diabetes is therefore just as important as it is for type 1 diabetes. Until now, evidence to support the use of CGMS in individuals with type 2 diabetes has been insufficient. A study by Murthy et al. Demonstrated that even intermittent use of real-time CGMS can lead to 0.6% improvement in HbA1c and a reduced risk of microsomia in pregnant women with type 1 diabetes or type 2 diabetes who are on insulin therapy. The positive outcome from Murthy et al. Study might be attributed by the researchers to the consistent use of real-time CGMS for up to 7 days, every 4 to 2 weeks, between 8 to 32 weeks, as a tool for the patient education rather than relying on the patient to adjust their insulin level of their own. So, GDM is the most prevalent form of hyperglycemia during pregnancy, thus the need for evidence to support the benefit of CGM in managing GDM is urgent. So far, little evidence is available on this. 2 meta-analyses have evaluated the effect of real-time CGMS in a meta-analysis of 6 RCT involving 482 people with GDM. CGMS led to only participants who were using insulin treatment, which suggests that the benefit of CGM are primarily limited to individuals using insulin. Recently, in one study, they showed that a benefit of CGM for the perinatal complication in GDM. That studies found that SMBG group had a 5.3 times high risk of fetal macrosomia than the patient on the CGM group who used it intermittently in the first 4 weeks after a GDM diagnosis. So, the current guideline says that based on the finding of concept trial and real world study of Swedish cohort type 1 diabetes, the ADA in 2023 suggests that real-time CGMS can decrease the incidence of macrosomia and neonatal hypoglycemia in pregnancy complicated by GDM. The UK national guidelines, that is NICE guideline updated in 2020, suggests real-time CGMS can be used for and to be offered to all pregnant women with type 1 diabetes. Currently, there is no enough evidence to support use of CGMS in individuals with type 2 diabetes or GDM. Therefore, guidelines do not strongly recommend the use of CGM in those individuals. Although CGM might have a potential benefit during pregnancy, the ADA mentions only that CGM combined with SMBG can help to achieve the HbA1c target. The NICE guideline have a stronger recommendation than ADA guidelines indicating the real-time CGMS should be used during pregnancy in patients receiving insulin therapy. Recently, ADA has said that the pregnant patient who are using insulin should be using CGMS. This is the latest one. But in GDM and in type 2 diabetes with pregnancy without insulin use, the recommendation is not that strong. Thank you very much.
You're such a very nice presentation about the latest advancement in management of diabetes during pregnancy. Only one thing I would like to know, that is this machine available in Calcutta?
Yes, there is a stall there.
It is there. Because we in our hospital are using fasting, PP and all that only.
Yes.
Okay.
They
And definitely it will decrease the complications of diabetes, because variability will be reduced, because the patient will be able to monitor their own blood sugar.
Just have to push, keep the mobile like this, they will be getting
Okay. Okay.
Ringing, you hold it. That is a practical.
But definitely that will cause a reduction in the complication rates. There is no doubt about it.
Guideline says that you cannot rely entirely on the CGM. Patient have to do twice at least SMBG also.
Yes.
Regulate them, because that is not so accurate.
Achha,
Because we are measuring capillary blood, interstitial level of the sugar. So there is some
And
difference.
what is the cost?
4,000 rupees.
Madam, it is 5,200. The sensor is there for 14 days and you can have as many reading as possible. You can have the graph. When the patient is sleeping, the glucose is being monitored. The only thing is it not the capillary blood, it is the interstitial fluid blood. So there is some time lag in the blood between the blood glucose and the interstitial fluid glucose management. So, but nowadays the advanced machine, they have got a mathematical formula, so they give you approximate same.
Sir, how interval it will be changed that device? How interval you will change this device?
How often?
Huh.
It is after 14 days.
And who will do that? Patient itself or we?
Anybody can do it. It is
Anybody.
so simple. Or the company people will come, or the patient may come to our clinic. We can do it. It is just a sensor, like just a ECG lead type.
And the patient who is trying for the pregnancy and have a type 1 diabetes, is it okay to insert this device pre-conceptional?
Actually, this is being used even for the non-pregnant person. So it is a measure to control the glycemic, for the glycemic control measurement. Anybody who wishes to know their glycemic control can use it. Because pregnancy, the criteria are different. You need to have good glycemic control to have a better outcome both for the mother and the baby. So you need to have a better control. That's why you want to have certain modalities where you can know the control, how is the control going. The patient may come after 15 days, HbA1c is very good, but the patient might be swinging like this. This CGM gives you an idea. Even if the patient is not telling, you ask the patient to show your record, CGM record, you will be able to know. Sometimes you know, if I eat a chapati, what is happening to my blood glucose? If I eat rice, suppose I have eaten rice, then what is the blood glucose is behaving? So you can modify your diet even based on that.
Yes. Definitely that will be a
Then
big
Dr.
advancement in the management of diabetes, and complications rates will go down.
Yeah,
If
but
the-
the only thing
if
is
it
there had
can
been
come
no
in regular
there-
practice.
There had been no outcome studies based on this. When the patient, this had been used in type 2 diabetes with pregnancy and the GDM. But HbA1c control has been better with these changes. Thank you very much.
Thank you very much.
Thanks a lot for a very informative and innovative session by Ojha sir.